Доброго дня, шановні глядачі. Наскільки я розумію, ми зараз уже...
Good afternoon, dear viewers, dear listeners. We're on the air now, and I think we're gonna wait a little bit for now the viewers, for all the listeners that are joining. That will take a few moments, like a couple of minutes, 2 or 3 minutes, and we're waiting for everyone to join, and then we're gonna start. Well, as far as I can see, the people are coming in just little by little, and I can see that you can see in your comments what location you're from, and this is our wonderful tradition. So please, while we're waiting for all our colleagues or all viewers, please do not forget, make sure that you use the chat box of our Zoom broadcast. As far as I can see, there are people coming in from all Ukraine, and we got Nikolaev, we got Kryvyi Rih, we got Kropivnitsky, we got Kyiv, we got Alexandria, and it's wonderful. And I like the way you do it very fast. Like all our viewers are joining in, so I suggest that we still wait like half a minute, and then we're gonna get started, because it's already 3 o'clock, and according to our plan, we got to get started. So we really need to start. Dear viewers, dear listeners, I can see that some of you are raising your hand, and I would like to ask you to actually write your questions on the chat, because unfortunately we don't have the possibility to use your voice to hear your questions, but whatever you write in the chat, all your questions and comments will be translated and handed over to the speaker on the air. So you may not use your speech function and the hand raised, but rather write it down in the chat. Okay, dear colleagues, without further ado, I'd like to welcome you at the Public Health Center, and we're grateful that you have switched on to our webinar. And this is operative prevention of infectious diseases. That's the prevention of preoperative prevention of surgical site and for surgical sites infection, and we're gonna talk about how to deal with the wound and other questions therefore. And it's just to remind you that this is the second webinar in the row, and the topic of these webinars is the European experience of infection control and the use of AMR drugs, and we're talking about things that are promising for Ukraine. And first of all, I would like to thank you for the organization, actually, that it was the result of cooperation, and it was our partner that made the contribution, is ICAP from Lviv University, and we got experts and speakers from the European University of infection control. And our today's webinar, we have the expert professor, University Professor Nicola Petrosillo from University Hospital Bio-Medico campus, and he's from Italy. So today he will present to us his report. And traditionally, I urge you to be active, to stay active in our chat. And at the end of the webinar, we got a Q&A session. So please write your questions and comments, and we're going to translate them and pass them to the expert. And our expert, Professor Nicola, will give answers to those questions. And today's webinar is for about 1 hour and a half of our efforts, and half an hour will be for questions and answers. And also, I would like to remind you that all our webinars will be recorded, and they will be available on the YouTube channel of the Public Health Center afterwards, and also in the social networks of the Public Health Center. In our social networks, we will also publish announcements and ads for our forthcoming webinars. So make sure you sign up and subscribe and follow. And it seems to me that I've said it all for the introduction. Maybe later down the road, we're going to get back to some sort of housekeeping things. And now I would like to pass the floor to our expert, Mr. Nicola Petrosillo. And the floor is his. Welcome, please. Floor is yours.
Thank you very much. Thanks to ICAP, to the organization, and to all Ukrainian colleagues who contributed to this meeting. My presentation will deal with the prevention of surgical site infection. Next slide, please. Next one. Okay. I am chair of the infection prevention and control at the University Hospital Campus Bio-Medico in Rome, Italy. Next one, please. As you see, a surgical site infection is defined as an infection following surgery at the incision site or in its immediate proximity. From an epidemiological point of view, surgical site infections are divided into superficial, deep, and involving organ space. The so-called superficial infection involve the skin and subcutaneous tissue of the incision site, and they occur approximately within 30 days of the operation. The deep incisional infection involves the deep structure of the incision site, for example, the muscle, and occur within 90 days of surgery. And finally, organ space infection affect the structure underlying the muscle, manipulated during surgery, and they occur within 90 days of surgery. The next slide, please, will show you exactly the site of the infection after surgical site, after surgery, and you can see the superficial incisional surgical site infection, the deep, and the organ space involving organ and space. Next one, please. The surgical site infection occur in almost 0.5 up to 10% of surgery, and depend on the type of surgical procedure and the incidence density of in-hospital surgical site infection account for about 0.1 up to 5.7 infection per 1,000 postoperative days patients. And you can see that the most important prevalence, European prevalence survey on healthcare associated infection conducted from 2016-2017 involved 29 European countries, more than 1,200 hospitals, and more than 320,000 patients. And in this survey, a total of 624 healthcare-associated infection with a prevalence that is very close to 6%. I'm talking about prevalence, 6%, 5.9% of infection. And the surgical site infection represented 18.9% of the total infections. What is very interesting is that a lot of infections were present upon admission to hospital, but the majority, 1/3 of them, were represented by surgical site infection. Next one. It means that up to 71% of surgical site infection occur after hospital discharge. Therefore, post-discharge surveillance systems are necessary to evaluate the real burden of the phenomenon, of this phenomenon in terms of public health. Next one, please. The other big problem of surgical site infection is the economical impact. In economic terms, surgical site infection responsible for increased hospital cost. In the United States, there is an estimation of around $10 billion per year due to surgical site infection, but also surgical site infection responsible for prolongation of stay, reoperation, rehospitalization, and finally, last but not least, high mortality rates. Next one, please. And in this slide, you can see how much is the amount of currency of any surgical site infection that in European euro, it's up to 32,000 euros per surgical site infection. Next one, please. Moreover, the surgical site infection is one of the 6 important healthcare-associated infections responsible for the a high rate of disability adjusted life years. As you can understand, this infection have high burden of deaths, and almost 1/2 of deaths are attributable to this infection. And moreover, the multi-drug resistant organisms are responsible for some of these infections. Next one, please. Talking about prevention of healthcare-associated infection, especially of surgical site infection, we have to underline which are the modifiable and non-modifiable risk factors. In this slide, you can see that there are some factors that can be modified, like diabetes, because hyperglycemia impairs the immune system and promotes glycosylation of proteins. They compromise the wound healing. So diabetes can lead to higher perioperative glucose levels and hyperglycemia that is more difficult to treat. And this is modifiable. Another factor that it can be modified, it's the use of immunosuppressive medication and condition. Immunosuppressive clinical condition medication can decrease the inflammatory phase of the wound healing. Another factor that can be modified is malnutrition. Malnutrition can decrease the collagen synthesis, can decrease the granulation formation in surgical wounds, and resulting thus in poor tissue healing. Another factor that can be easily modified is obesity. Obesity, because adipose tissue has less blood flow. and this inhibits the delivery of oxygen and of course also the delivery of antibiotics that are given. Another factor that can be modified is the presence of pre-operative infection. Prior to elective surgery, it's important, therefore, to recognize and to treat all infection, even if they are distant from the surgical site. Finally, a very modifiable factor is the use of cigarettes, tobacco. Tobacco use causes vasoconstriction, and that vasoconstriction increase the alteration in collagen metabolism, decrease the inflammatory response, and it's an impact on the ischemia of tissues. But among the risk factors, there are also non-modifiable risk factor. Age cannot be modified. We can do our best, but age cannot be modified. History of prior skin and soft tissue infection cannot be modified because a history of skin and soft tissue infection may be indicative of issues with inherent immunity propensity for infection. And finally, history of radiation therapy that cannot be modified. The treatment with radiation induces underlying tissue injury and inhibit wound healing. Next one, please. Regarding the operation-related factors, we have some factors that are very important. The airborne contamination that can be modified because most of the airborne pathogens are generated by people in the operating room and their movements. So overcrowding in the operating room is one of the causes of airborne contamination, and this can be prevented. The use of anticoagulation during surgery, it's another important problem because anticoagulants may generate continual oozing of the incision and slow wound healing. The use of a blood transfusion as well can impact macrophage activity and can influence the infection risk. Another factor that it's a risk factor for surgical site infection during surgery, operation-related factor is the decreased tissue oxygenation. The decreased tissue concentration of oxygen, it's the primary cause of ischemia, the primary cause of the difficulty of wound healings. Low oxygen settings can curtail the efficacy of perioperative antibiotics. Another factor that is an operation-related factor is the use of foreign materials, foreign devices. Foreign devices stimulates inflammation on the surgical site and raises the risk of surgical site infection. And finally, the length of the duration of the surgery. Long operative time is associated with higher damage in wound cells, wound contamination, and exposure in the outside environment. The longer is the operation time, the longer is the risk of exposure to contamination of the surgical site. Next one, please. Another operation-related factor that can be modified is the perioperative hypothermia. Perioperative hypothermia weakens immune system protection against surgical wounds contamination and can be modified by the normalization of the temperature of the body. Another factor that can be modified is the post-operative hyperglycemia, because as you know, some cellular functions of bactericidal activity, leukocyte chemotaxis, phagocytosis, are enhanced by insulin and glycemic control, and there is a direct relationship between elevated blood glucose and cellular function deficit. This relation is independent from diabetes. It depends only on hyperglycemia that can be temporary as well. The surgical technique is another important, could be an important risk factors during the operation, because wound healing is decreased by leaving the devitalized tissue. And necrotic tissue can represent a source for infection. Moreover, the wound care, it's another important risk factor for infection can be modified. Wounds that remain uncovered following surgery can be contaminated, or uncontrolled drainage can diminish the integrity of the surrounding skin. And finally, wound contamination from patient's own flora, because the patient's own flora can contaminate the surgical site. Wound classification delineates the degree of contamination of surgical wound at the time of the operation. And the skin preparation and the perioperative antibiotic administration reduce, but does not eliminate, the introduction of microorganisms in the surgical site. That's very important, because to reduce the wound contamination can decrease also the risk for surgical site infection. And here we have to say that shavings leads to microscopic cuts in the skin that can become sources for bacterial to multiply. Next one, please. And finally, among the risk factors that can be modified that are operation related, I want to mention the wound contamination from operating room personnel. Transition of microorganisms from the surgical personnel, shoes, mouths, or body can contaminate surgical wounds. Microorganisms from the hands of healthcare workers in the operating room can move into the patients and operating fields if personnel do not perform appropriate hand washing or gloving. And finally, wound contamination from surgical instruments, because sterilization eliminates all microorganisms on the surface of surgical devices, surgical instruments, using not insufficiently sterilized tools can lead to pathogen transmission. Next one, please. So you see that there are at least three main opportunities to prevent surgical site infection. Before surgery, we have seen that prolonged preoperative stay is one of the factors for contamination of the skin. The presence of coexistent infection in other body sites, the endogenous colonization, and it means antiseptic bath, the colonization protocols, and finally the hair removal. So this is before surgery, and this is a great opportunity to prevent surgical site infection. But we also have other opportunity to prevent surgical site infection during surgery. The antibiotic prophylaxis, that is perioperative prophylaxis. We talk about that later. To reduce the endogenous colonization, skin disinfectant, asepsis, to give normothermia to the tissues, to give supplemental oxygen, and to control the glucose level during surgery. Finally, after surgery, we have as an element for reducing the risk for surgical site infection is represented by appropriate wound management. Next one, please. In this slide, you see that one of the most important strategies for prevention surgical site infection is to use a checklist based on, for example, the World Health Organization. There are some items in the surgical checklist to ensure the adherence, the compliance to the best practice. And you can see in this slide that by using the appropriate checklist, we can reduce significantly the risk for surgical site infection. Next one, please. And you can see here an example of the checklist by WHO. Sorry. You can see an example of the checklist, surgical safety checklist of WHO, in which for every item, you can be sure that everything is going nice and that all the procedures are respected. Next one, please. In 2016, WHO issued global guidelines for the prevention of surgical site infection. Next one, please. These guidelines were published on the Lancet Infectious Disease, and you can see here the authors of the guidelines and the grade categories for the quality of the evidence, because all the recommendations are based on evidence from the literature. Next one, please. One of the first recommendations deals with pre-operative batting. The question is the pre-operative batting using an antimicrobial soap more effective in reducing surgical site infection compared to batting with plant soap? And the recommendation it's a good clinical practice for patients to bath or shower prior to surgery. And the panel of WHO suggests that either plant soap or antimicrobial soap may be used for this purpose. And the other question is preoperative bathing with chlorhexidine impregnating clothes more effective than antimicrobial soap? The panel decided not to formulate a recommendation the use of chlorhexidine impregnated clothes as compared to the antimicrobial soap. In other words, there is not a big difference, but what is important is the pre-operative bathing of the patients. Next one, please. There's another important recommendation regarding the decolonization with mupirocin ointment with without chlorhexidine body wash for the prevention of Staphylococcus aureus infection in nasal carriers of Staphylococcus aureus. The question is if mupirocin nasal ointment in combination with or without chlorhexidine body wash is effective in reducing number of Staphylococcus aureus infection in people carriers, nasal carriers undergoing surgery. The recommendation, the panel recommend that patient undergoing cardiothoracic orthopedic surgery with known nasal carriage of Staphylococcus aureus should receive perioperative intranasal application of 2% intranasal application of mupirocin ointment with or without a combination of chlorhexidine body wash. There is next one, please. And in this slide, you can see the reference from the literature that was published on JAMA in 2023 of a meta-analysis of 5 randomized controlled trials in which decolonization versus non-decolonization is strongly effective in reducing surgical site infection in nasal carriers of Staphylococcus aureus. Next one, please. Next, okay. Another important topic is the optimal timing for pre-operative surgical antimicrobial prophylaxis. The question is, how does the timing of surgical antimicrobial prophylaxis administration impact on the risk of surgical site infection? And what is the precise optimal timing? And the panel recommend that surgical antimicrobial prophylaxis should be given prior to the surgical incision when indicated, depending on the type of operation, within 120 minutes before incision, considering the half-life of the antibiotic that is used. This is a strong recommendation with a low and moderate quality of evidence. Next slide, please. And in this slide, you can see that the administration within 30 minutes before incision versus 60 minutes does not make any big difference, but the big difference is given when 30 minutes is compared within 30 minutes before incision versus after incision. So to give the prophylaxis before the incision is strongly related, strongly significant tool for reducing surgical site infection. Next one, please. And the European Centers for Disease Control clearly mention all the strategy for perioperative antibiotic prophylaxis to have a multidisciplinary antimicrobial management teams. That's very important. To give the responsibility for appropriate timing of perioperative antibiotic prophylaxis. This responsibility should be given to a specific component of the team, which is the timing of perioperative antibiotic prophylaxis. European Center for Disease Control mentioned 60 minutes. That is that before it should be antibiotic prophylaxis should be given within 60 minutes before incision. The design and duration of perioperative antibiotic, the dosing and duration of perioperative antibiotic prophylaxis, a single dose for a single day. In some cases, depending on the duration of the operation, can be given another dose, or if there is bleeding, can be given another dose. Finally, the duration and termination of perioperative antibiotic prophylaxis, because continuing antibiotic prophylaxis after the end of surgery is not recommended. Next slide, please. Another issue is represented by mechanical bowel preparation, the use of oral antibiotic. The recommendation is that preoperative oral antibiotics combined with bowel preparation should be used to reduce the risk of surgical site infection, not mechanical bowel preparation alone. Next one, please. Air removal is another important point. Does air removal affect the incidence of surgical site infection? What method should be used for air removal? The panel recommends that in patient undergoing any surgical procedure, air should not be removed, or if it's absolutely necessary, should be removed only with a clipper. Shaving is strongly discouraged because it can generate little cuts of the skin that can be colonized and infected. The other problem is the surgical site preparation. And here the panel recommends that the alcohol-based antiseptic solution based on chlorhexidine for surgical site skin preparation should be given in patient undergoing surgical procedures. Next one, please. And this is what I said about air removal. There is a meta-analysis comparing clipping and no air removal versus shaving, and the no air removal should be the choice for surgery, but in case of when air removal is necessary for the surgical procedure, should be used the clipper. Next one, please. And here you can see the studies in the literature, meta-analysis of 19 randomized controlled trials and 6 quasi-randomized trials. You see that clippers are the best choice for air removal in case it's needed air removal. Next one, please. Regarding the surgical site preparation, as I said before, WHO panel recommends alcohol-based antiseptic solution based on chlorhexidine. And a meta-analysis of available studies show that alcohol-based chlorhexidine is beneficial in reducing surgical site infection compared to alcohol-based povidone iodine. Next one, please. In this slide, next one, please. May I have the next slide, please? I don't see anymore any slides. Okay, next one, please. Okay, thank you. You see that using chlorhexidine gluconate and alcohol skin preparation in another meta-analysis of 4 randomized controlled trials, we are talking in 4% chlorhexidine gluconate and plus alcohol versus povidone iodide alcohol. And there is a significant reduction with chlorhexidine gluconate, 2% in alcohol, sorry, for a reduction of surgical site infection. Next one, please. Regarding the use of antimicrobial skin sealants, the panel suggests that the antimicrobial sealants should not be used after surgical site skin preparation for the aim of reducing surgical site infection. Surgical hand preparation instead is very, very important, which is the most effective type of product for surgical hand preparation to prevent a surgical site infection. The panel recommends the surgical hand preparation should be performed by scrubbing with a antimicrobial soap and water, or using indifferently suitable alcohol-based and rub before donning sterile gloves. So hand washing, it's important definitely at all. Next one, please. Regarding the nutritional support, there is a need for enhanced nutritional support for the prevention of surgical site infection. The panel suggests considering the administration of oral or enteral multiple nutrient enhanced nutritional formulation for preventing surgical site infection in underweight people. And regarding the discontinuation before the surgery of an immunosuppressive treatment, the panel suggests not to discontinue immunosuppressive medication prior to surgery for the aim of preventing surgical site infection. A very important issue is the perioperative oxygenation. The panel of WHO recommends that adult patients undergoing general anesthesia with endotracheal intubation should receive a 80% fraction of inspired oxygen intraoperationally, and if feasible in the post-operative period for 2 to 6 hours in order to reduce the risk for surgical site infection. Next one, please. Another point, it's the maintaining the normal body temperature, the normothermia, and the panel suggests the use of warming devices in the operating room and during the surgical procedure for warming and so reduce surgical site infection. Also, the use of protocols for intensive perioperative blood glucose control is very important for reduce surgical site infection. This is underlined by the panel of WHO. And finally, the maintenance of adequate circulating volume control is another important aim for reducing surgical site infection. Next one, please. Of course, changing of surgical instrument can be very important. The panel decided not to formulate a recommendation on the topic. There is no evidence. The topic is at the time of wound closure, is there a difference in surgical site infection when instruments are changed for fascial subcutaneous skin closure using a new set of sterile instruments? There is no evidence, and the panel decided not to formulate a recommendation. Another interesting point, the use of antimicrobial coated sutures, and the panel suggests the use of triclosan coated sutures for the aim of reducing the risk of surgical site infection. And I have to say that this is a very interesting point, but should be connected with all the other infection control procedures. And finally, the problem of laminar flow ventilation system that are very expensive. The problem is the use of laminar airflow in the operating room associated with the reduction of surgical site infection, and thus the use of fans or cooling devices increases surgical site infection, if the natural ventilation is an acceptable alternative to mechanical ventilation in the operating room. The panel suggests that laminar airflow ventilation system should not be used to reduce the risk of surgical site infection for patients undergoing total arthroplasty surgery, orthopedic surgery. And there is no recommendation on the two topics on the use of fans or cooling devices or natural ventilation. Next one. And in this slide, you see clearly that regarding the maintenance of and monitoring of blood glucose levels, there are meta-analysis that clearly demonstrate the efficacy of reducing and monitoring glucose levels to prevent surgical site infection. And also there is a recommendation regarding the application of incisional negative pressure wound dressing that in a meta-analysis of 23 randomized controlled trials is associated with a decrease in surgical site infection. Next one, please. After all these recommendations from WHO, I think that the best one of them can be incorporated in a sort of bundle. This is one of the bundles that have been used in the clinical practice. You can see this is a 7-step approach, safe operating room, screen for risk factors and MRSA, MSSA, showers with chlorhexidine, skin preparation with alcohol-based antiseptics, suture with an antimicrobial coated suture, a solution to irrigate with chlorhexidine, and skin adhesive antimicrobial dressing to protect the incision. In this study published some years ago in the American Journal of Infection Control, there was a significant reduction in surgical site infection during implementation of the seventh bundle. Next one, please. The Global Alliance for Infection in Surgery bundles for the prevention of surgical site infection worldwide make the proposal to join their bundle, that is the preoperative bathing and showering, surgical antibiotic prophylaxis according with the WHO recommendation, hair removal according with the guidelines, surgical hand scrubbing preparation, and finally, skin antiseptic preparation. When all these points are implemented and are completely followed by the people, there is a clear decrease of surgical site infection. Next one, please. However, sometimes the problem is not so simple. In this article published a few years ago, it's clearly specified that the compliance it's an issue with the use of checklist and band implementation. And compliance may be the cause of some of the disappointing results, despite being in place for several years. We know that implementation of protocols can work in reducing surgical site infection with improvement of compliance using, for example, electronic prompts. But although there are tools to evaluate this, compliance is still variable, from 20 up to 60% in some countries like United States, United Kingdom, as represented in this article. Next one, please. Another interesting point that has been raised from this article from the Italian National Surgical Site Infection Surveillance Program is that on 355 surgical wards in which more than 60,000 operations were recorded, the number of the surveyed intervention doubled over the study period, and surgical site infection was observed in 2.6% of cases, and 60% of surgical site infection were diagnosed after discharge. Next one, please. But the most interesting point is that operations performed in hospital with at least 2 years of surveillance of surgical site infection behind them had a 29 lower risk of surgical site infection. And this is very important because just having a surveillance system can decrease by almost 1/3 the risk for surgical site infection. The final slide are my take-home messages. Next one. As take-home messages, surgical site infection, you understood, occur in about 0.5 up to 10% of surgical procedures, depending on the type of surgical procedure. And surgical site infection are responsible for increased hospital cost, length of stay, reoperation rates, rehospitalization, mortality rates. But what is more important is the surgical site infection of preventable infections. However, the prevention of surgical site infection is complex and requires the integration of a series of measures before, during, and after surgery. In each one of these phases, it's possible to intervene with measures whose effectiveness is demonstrated by scientific literature. The use of monitoring and surveillance tools will allow not only to verify the compliance to these effective measures, but also to reduce effectively surgical site infection rates. Thank you very much for your attention. Now, I think the Q&A section, it's for you.
Дуже дякую вам за таку докладну.
Thank you very much for such a meaningful and presentation, very much rich in content. And I can see really a lot of questions popping up in the chat. So can I just read it out one by one for you to answer? So question number one for you sounds as follows. So please describe how you go about monitoring the wound after the operation, if the so time is short after the operation, 3 to 5 days.
The surveillance, you mean the surveillance after surgery? How much is the length of surveillance after surgery?
Так.
Yes, indeed. Yes.
I think that any surgery should be followed intensively in the first 5 days after operation. I mean that the vision of the wound, the state of the patient, the redness in case of the incision site, all should be followed intensively in the first 5 days. This is very important, in my opinion, to be very aggressive in the first days after surgery in order to have a prompt diagnosis of any kind of surgical site infection, beginning from incisional surgical site infection. Next question.
А які основні процедури ви впроваджуєте?
So please describe the mainstream procedures that you implement following such surgeries.
Мається на увазі процедури.
I would like really to speak about those procedures, so to provide wound surveillance post-operative.
From an epidemiological point of view, the infection control nurse, or the nurse of the surgery, should every day write on the chart the condition of the wound site every day, and to write every day the state of the wound and the wound care that is applied. The application dressing can be useful, but sometimes does not allow a complete vision of the wound. So it's very important to have the daily vision of the wound. Regarding the procedures to be applied, if you are talking about antiseptics on the wound, it depends on the type of wound and depends on the surgery. Of course, it's important if you are using drainings, they should be in place for the less time as possible, because they can be a port of entry of microorganism within the surgical site. Next one, please.
Так, дякую, пане Нікола, за відповідь.
Yes, indeed, Nicola, for your answer. Our next question to ask is as follows. So do you perform, really, who is MRSA host amongst the clinical staff and amongst the patients, or do you do only MSSA detection? What is the strategy if you find out MRSA? What do you do in this case?
Staphylococcus aureus should be detected in I'm talking about carriage in any patient undergoing cardiothoracic surgery and orthopedic surgery with the implantation of a device. In my opinion, it's not important to differentiate between methicillin or resistant or susceptible Staphylococcus aureus, because both of them can be pathogens as well, and can produce toxins that can be necrotizing. So we perform nasal swabs in these patients, and in case of positivity, we apply ointment with mupirocin, that is, as you know, as a topical antistaphylococcal agents. We do not perform swabs for the operating staff at all, unless there is an epidemiological condition of, for example, a cluster of cases that cannot be explained, but just only in special cases. We perform routinely nasal swabs only to patients undergoing cardiothoracic and orthopedic surgery. Next question.
Добре. Так, дякую за
Good,
відповідь.
good. Thank you for your answer. Actually, our next question is about the antimicrobials. And the question is, which antimicrobials can be used for antimicrobial prophylaxis in case of ESBL spread in the hospital setting after 80%?
This is a good point. I think that the doctor that is asking this is talking about a condition in which there is an epidemic spread of microorganism producing Enterobacterialis producing ESBL. The problem is that chemoprophylaxis, antimicrobial prophylaxis, perioperative antimicrobial prophylaxis has the aim to prevent the exogenous contamination of the incision, the wound. That it's a question of intraoperative surgery. And most of microorganisms that are implied and involved in this contamination are gram-positive microorganisms. So in most of surgery, the prophylaxis is cefazolin, that is a cephalosporin active against Staphylococcus aureus susceptible to methicillin. In case in which the rate of methicillin-resistant Staphylococcus aureus, it's over we don't have a precise cutoff, but it's, in my opinion, if we have more than 15% of prevalence of methicillin-resistant infection in the surgical site, and no infection control procedure was active to reduce this rate, we can propose the use of vancomycin for prophylaxis. Regarding Enterobacterales, this is only a problem of abdominal, it's the major problem of abdominal surgery. And in this case, in these cases, it's not an exogenous contamination, but it's an endogenous contamination. And in this case, we have different measures for preventing the spread of infection than only giving antimicrobials. Next question.
Добре, так.
Good. Thank you for the answer. And now the next question is, how do you monitor SSI, surgical site infections, after the patient is discharged from hospital?
This is a good point. This is a good point because in some years ago, I carried out the national Italian study on surgical site infection in several hospitals, and with the aim of assessing the real burden of surgical site infection, because most of patients are discharged after a few days after surgery. Sometimes they manifest, they have the infection when they are at home. In this study, we had a very good team of nurses in all these hospitals, and they made telephone calls to the patient themselves. They were connected with the practitioners, the family doctors of this patient, and for everyone there was a call asking if their wound was healed or was open, it was draining, and they were taking antimicrobials. All this was done by specialized nurses in infection control. It's a big job. It was a big job for them, but finally we had a clear vision of the burden of surgical site infection post-discharge. And we were able to assess that up to 65% of surgical site infection were evident after discharge. Most of them were superficial surgical site infection, but sometimes some deep and very rarely, luckily, organ space were evident as well. Next question.
Так, добре. Дякую за відповідь.
Okay, good. Thank you for the answer. Next question sounds like this. How do you do surveillance over surgical wounds to prevent surgical site infections after discharging from hospital? And I wonder who does this and who monitors the patients after their discharge?
This is one of the points that it's not so easy to reply, because it should be the practitioner, the doctor, the family doctor in charge for this surveillance. In any case, all patients should be advised after discharge that any problem of the surgical site should be referred to the family doctors that will be connected with the hospital or the healthcare setting where the patient was operated. I understand that sometimes it's not easy, but a good organization with a net of doctors that have been educated on this problem can be very helpful. The family doctors represent the key for the surveillance and for the prevention of the development of surgical site infection after discharge. Next question.
Так, зараз наступне питання.
Now, next question is how do you do to the wounds with a manifest subcutaneous tissue, with a visible subcutaneous tissue? Do you use drainage? Do you use drain?
The use of draining, it's up to the surgeon. I'm not a surgeon, of course. The use of draining is up to the surgeon. Honestly, I discourage the use of draining for any surgery because sometimes there is no need. Sometimes the use of draining is only a way for the surgeon to be much confident with the operation and to be sure that any infection will be covered. In my opinion, draining can be very dangerous. Draining, it's a procedure that should be applied only in case of proven infection and proven accumulation of draining in some organ space, but not as a prevention tool for surgical site infection. I am against the use of draining for the prevention of surgical site infections. Next question.
Добре, так, дякую за пораду. Наступне питання.
Thank you for the question. Next question is we got the two very similar ones on the same topic, so I will read them through both. The first one, do you examine patients for Staphylococcus and Clostridia difficile? Do you research them? And another question is, who is surveyed for Clostridia difficile, and what is the perioperative preparation and prevention in case it is detected, the Clostridia is detected?
That is an important point. Clostridium difficile, it's an infection caused by a spore. It's generally caused due to the dysbiosis of the microbiota of the gut. Due to the dysbiosis, generally is due to the use and overuse of antimicrobials. Antimicrobial will impair the microbiological organisms that are in our gut. And only the balance of all the families of microorganisms can guarantee that infection due to microorganism like Clostridioides difficile can occur. So the first important point is to reduce as much as possible the use of unnecessary antibiotics. Because they can induce dysbiosis in the gut, and in some cases that can be the cause for the Clostridioides difficile infection. The question is how do we detect Clostridium difficile infection? Of course, we are talking about people with diarrhea. Most of them have diarrhea, and in the hospital setting, half and more cases of diarrhea are due to Clostridium difficile infection. So a patient with diarrhea after surgery should be immediately detected for Clostridium difficile. Stools, diarrheal stools should be immediately sent to the lab. And if there is a high suspicion of Clostridioides, anti-Clostridioides difficile treatment should be started as soon as possible, waiting for the laboratory results. In general, we do in the laboratory, we use the double-step diagnostic tool, beginning with the GDH, and if GDH, that is the antigen, is positive, the laboratory perform the search for the toxins A and B. As you know, the B toxin is responsible for diarrhea, and this search for toxin A and B are due by the immunoenzymatic method. In case in which there is discrepancy of the results, we can use also the molecular biology, the PCR, the NAT system that can detect the gene that produces the toxin. So when the test is positive and we are sure that it's C. diff, Clostridium difficile infection, we can continue with the treatment that in a very high risk patient we have already started. And the treatment should begin for 10 days. Currently, we use orally vancomycin, 125 milligram 4 times per day for 10 days, or the more expensive fidaxomicin, that is much more expensive, that should be given only in very high risk for recurrence people, because one of the problem of C. diff infection is that 20% up to 20% of people after the primary episode of C. diff infection can have a recurrence. And if they have a recurrence, the risk for a second recurrence is 30-40%. For the third recurrence, it's a 60%. This is a very, very important point that sometimes leads us to stool transplantation and other important procedures. In some cases, when the Clostridium difficile infection is severe, we also have to perform surgery with colectomy. Any question?
Так, дякую за розгорнуту відповідь. В нас...
Thank you for the very detailed answer. We got the next question. And the next question sounds like this. What particular groups of patients have to be studied for Staphylococcus? For example, if they have a hernia, do they have to be studied for Staphylococcus?
If they only have hernia, yeah, I think that the colleague is talking about nasal carriage. The nasal carriage only for hernia, it's not needed. As I told you before, the detection of the nasal carriage, it's important for preventing cardiothoracic and orthopedic infections. So it's only for cardiothoracic and orthopedic infection. Of course, if you have a patient with a history of staphylococcal infection, recurrent staphylococcal infections, some of them should be very deeply studied, because maybe for some of them, if they have a history of recurrence of staphylococcal infection, they should undergo chlorhexidine baths before surgery. And in these cases, maybe it's also helpful the detection of the nasal carriage with the decontamination with ointment, mupirocin ointment, but just in selected cases, not in all cases of minor surgery. Next.
Добре, наступне запитання.
Good. Our next question is what groups of patients need to be studied or tested for staphylococcus? Sorry, not staphylococcus. I'm just repeating the same question. Sorry,
Yeah,
I'm
no
getting
problem.
to the next. Okay. Now, my question is, what measures do you take to clean the surgical site after the surgery on a wound?
Oh, this is, of course, it's up to the surgeon and to the surgical staff. Generally, they clean the skin surrounding the surgical site with the same antiseptic that they used for the antisepsis of the skin. If I suggest that 2% chlorhexidine alcoholic solution is the best for skin antisepsis, and after surgery, all the skin surrounding the cut should be disinfected with this antiseptic, 2% chlorhexidine in alcohol. If you don't have 2% chlorhexidine in alcohol, because for some reason in your hospital, you can use povidone iodine as well. Next.
Так, дякую за відповідь. Це була...
Yes, thank you for the answer. So it was last but not least question really to ask in our chat. So for this purpose, so Mr. Nicola, thanks very much for your answers given. And I just would like really to hand over to share. So big thanks by our participants in the chat box. And actually they are saying that the lecture has been very fascinating, amazing, and it will come in handy for them for sure. And on behalf of the Ukraine Public Health Center, we are very appreciative of your participation in this webinar here. And for our participants, for our viewers, I just would like really to share a reminder that all of the materials with the video recording shall be uploaded to the UPHC related website and also in the social media. And for all the subsequent announcements of all these webinars, so kindly announce on the web pages of our social media, and feel free. So after this video shall be uploaded pages, so we will share more comments and we will do monitoring to find out the feedback and response rate. And I'm just really thankful to all your active participation. Thanks very much for this useful webinar, and see you soon up next in our forthcoming webinars.
And I thank you, everyone. I thank you all, the organization, all the people that I see. There was a lot of people listening to this webinar. Thank you very much.
Дякую, тож завершуємо нашу
So in that case, we call it a day.
І всім до побачення.
And see you soon. Bye-bye.